My name's Matt Beal. I'm an A&E SHO from Norwich. So I'm currently taking an F3 year, so I'm one of these F2s who decided to take some time out because of the contract changes and sit things out and see what happened. So I'm here to talk to you about some research that I did, and I started a couple of years ago during a Masters in Clinical Education. So I integrated whilst I was at medical school and took some time out, and I spent the year lecturing and as a PBL tutor for the junior medical students. And I did quite a lot of work into problem-based learning and into simulation-based teaching. And I did a systematic review and meta-analysis looking at how effective simulation is in medical students, and I'm going to talk about that today. So I'm briefly going to go through the background, sort of how we got to this point, and I'm going to touch on some of the learning theory, just very basically, and why things might be slightly different for medical students. I'm going to go through the methods, results, and then obviously what this means. So I know this is a simulation conference, but I thought it would be useful just to kind of start with a definition of simulation to make sure that we're all on the same page. So simulation is a process. It's a process of recreating characteristics of the real world, which allows us as learners and educators to carefully control aspects of the learning environment. So despite being expected to treat and identify critically ill patients from pretty much day one of your job as an F1, there's still no common undergraduate curriculum in acute care skills. Even with courses like ALERT and ALS, across Europe, about 20% of medical schools don't even teach advanced life support, and actually about 3 or 4% don't even teach basic life support. Simulation is an incredibly expensive way of teaching. If you need to teach medical students a particular topic, you can have a lecture theatre like this one, probably squeeze in 150 students. You have one lecturer in probably an hour's time. But with simulation, you're probably talking about 2 members of faculty, probably about 150 hours of simulation. So of course the costs with that are a lot more expensive, and few studies have really gone into the depths of how much simulation really costs. But with the amount of time and money that we're investing in simulation, I think there's a real need to justify why we're doing that and whether it's really worthwhile. So I started looking at this after doing my elective. I did my elective with London HEMS, and they're quite interesting. They aim to do pretty much a daily simulation up on the helipad at Barts and the London, and they use a type of low fidelity simulations. They call it moulaging, and they have low fidelity simulators, and they aim for high environmental fidelity, so high environmental realism. So they do it outside in the rain and all of those kind of fancy pre-hospital type things. And when I was doing this, I noticed that medical students seemed to come away with very different kind of messages from the simulation than the more senior registrars, the more senior doctors who are there on secondments. And it made me just start thinking about whether simulation really is as effective in medical students as it is in other trainees. So I started reading, and I found a huge body of evidence in more senior trainees, and I found quite a big body of evidence in medical students. But actually, particularly in medical students, I found the messages were quite mixed. I found some studies showed very large and positive effects with simulation. Others were equivocal, and others actually showed negative effects. So the idea of putting together a more formal review of the evidence sort of formed. So why might medical students be different? I mean, we've already heard a bit about cognitive load theory. So as humans, we have an excellent long-term memory. We can remember things that happened 20 years ago. But actually, we can only store a few very small pieces of information in our short-term memory at any one time. And what that means is when we're trying to learn something very complex, our short-term memory can become overwhelmed very quickly. And that's essentially called cognitive load, as the load on your memory sort of increases. So of course, your level of expertise and how used you are to managing particular problems and working in particular environments can affect how efficient you find that learning. And simulation as a process and a method in itself can place a high cognitive load on learners. So for instance, in simulation, just the very format of simulation, there are lots of things that you have to take in and buy into in order to engage with the learning process. So for instance, just the fact that there's an audience, the fact that there might be cameras, and you're dealing with not a real patient, an electronic mannequin or a piece of plastic. Those are things that take part of your short-term memory to process. And that short-term memory is then taken up and away from the learning task. The other thing which is different in simulation compared to, say, lecture-based teaching is in lectures, you can control as and when a student gets to particular learning points or different elements of the learning. Whereas in simulation, students tend to be a bit more in control of how quickly they get to different parts of the simulation. And that's called the intrinsic cognitive load. So all of these things are things that take up your short-term memory. So I'm going to talk very briefly about what we did. I obviously don't have time in 20 minutes to go through it in detail, and there is a link to the full research protocol in the electronic handbooks if anyone's interested. It's quite long, so I'd recommend that you don't have a look at it now. So what we did is we included studies which were randomised control trials comparing the effectiveness of simulation compared to other teaching methods, no teaching or comparing more than one type of simulation, obviously medical students. We decided to include any acute care specialities, so critical care, anaesthetics, emergency medicine, trauma, and we didn't find any studies which looked at pre-hospital medicine. We included basically any type of simulation, so both low and high fidelity mannequins, standardised patients, so that's like actors and that kind of thing, screen-based computer simulators, and we didn't find any studies that used animal or human cadavers. And we looked for studies that had outcomes of knowledge or clinical performance. So this is just a graphical representation of the search strategy. And so very broadly, we searched for simulation, setting, critical care, randomised control trials, and medical students, combine them all together, and I'll show you the full search strategy in a minute. After doing that, we went through all the references and the citations for all of the papers that we identified, and then we wrote to all of the authors asking for any unpublished literature. And that's the full search strategy if anyone's interested. Following that, we went through all of the abstracts. So at this point we had 2 reviewers all the way through who were working in parallel but separately so that we could try and reduce the risk of selection bias through the systematic review. So we screened for any potential eligibility, aiming for sort of a higher sensitivity than specificity, aiming for sort of over-inclusion at that point. We then gained all of the full texts and did a very similar process with those. And we used piloted checklists to do that, to make sure that everything was nice and traceable and reproducible. And then we went through the data extraction process using a 13-page standard and piloted pro forma. Through the first 2 stages, there was no disagreement at any point between either of the reviewers. And in the last stage, the only disagreements were to do with missing information, so information that had been missed in the text, rather than disagreements in meaning. So what we found. So this is the study flow diagram. So we screened approximately 1,300 abstracts, and that identified 44 full texts. And from those 44 full texts, we excluded 22 papers. Now, the one that's really relevant is the non-English papers. This was a paper that was in Mandarin, and I had a colleague who speaks Mandarin translate the paper for me. And it would have been includable, but we weren't able to fund the full translation, so unfortunately we had to exclude that paper. So we included 22 papers in the review, and then 15 made it through to the main meta-analysis. So the studies that were excluded, this is just to kind of explain why it's only 15. So 2 of the control group received no teaching. So the simulation group had simulation, and the other group was sat in a room basically with nothing to do. These 3 studies compared 2 different types of simulations, so that wasn't includable. And then 2 of the studies had insufficient data. So one, the paper by Morgan, had varying numbers of participants as you looked through the paper, and unfortunately the author was unable to clarify that for us. So we had to exclude that paper. And the other paper was presented with medians and interquartile range, so statistically it wasn't really appropriate to include that in the meta-analysis. So most of the studies were done in sort of medical students towards the final years of medical school and across a broad range of acute care topics. Most of the studies used high fidelity simulators, About a quarter used low fidelity simulators, and there was a smattering of screen-based computer simulation, standardised patients, and voice advisory mannequins. Those are the mannequins that you practice CPR on, that give you feedback about the quality of your CPR. And there was quite a wide variety of control groups as well. So we used the Cochrane risk of bias tool, and across the whole sort of review, and we had an unclear risk of bias decision. This was mainly due to incomplete reporting and failure to mention a particular thing. We tried to chase up authors to find out a bit more information, but were largely unsuccessful with that. So this is the sort of headline results, really. So this is simulation compared to other teaching methods. So what we found was that simulation was more effective than any other teaching method, and that was with a standardised mean difference of 0.84. So generally in research, standardised mean difference of about 0.8 would be considered as a large effect. But actually in education, we know that effects of about 0.2 can be useful or important in policy making. So actually this is a very large and important effect size. Probably more relevant to most of you is how this affects individual students, and that's worth having a look at the percentile gain. So the average student in the simulation group would be in the 99.9th percentile of the non-simulation group. So that's obviously a huge increase and advantage for those students. Now the obvious flaw here is the inconsistency between the studies, and I think I've already mentioned that really. So you see how spread out the studies are on the forest plot. So we're unable really to explain that. I'm going to go through some of the things that we did to try and explain why that is. But on the plus side, the vast majority of the studies showed a positive effect. There was only I think 2 studies that had a negative effect. Well, I'll go through that in a minute. So this is a funnel plot. This is just to try and assess the risk of publication bias. So this is the bias caused by failure to publish studies with small or negative effect sizes. So what you're really looking for here is a sort of funnel shape. And as you can see, there is a gap down here, which is where the small studies with negative effects should be. However, having said that, because all the studies were reasonably small, so the biggest study had 144 participants, actually statistically they're really quite grouped together. So statistically you can't really say that there's definitely any asymmetry here, but there is a small suggestion. What's more interesting here, I think, is the grouping of the studies that are at high risk of bias, in that they all have the largest and most significant effect sizes. So what we did to try and explain the inconsistency between the studies is a load of subgrouping and sensitivity analysis. So we subgrouped by time to outcome assessments. That's the time from the simulation session to the assessment, the type of simulation, type of control group, the type of outcome measure, the dose of simulation, and the year of study. And I'll go through just a couple of those in a minute. The rest will be in the main manuscript when that comes out in a few months. We also, crucially, that subgrouping didn't explain the inconsistency that we saw. Furthermore, we did a sensitivity analysis as well. Now, this is removing studies from the analysis to see what effect that has on your effect size. So we removed all the studies that had high risk of bias, industry funding, had used the same simulator in the assessment as in the teaching session, because obviously that puts the students who had simulation at an advantage because they're already familiar with the simulator, and then crossover and imputation of statistics because of the statistical issues surrounding putting those kind of studies into a meta-analysis. And crucially, those doing that sensitivity analysis maintained a statistically significant and large result. So this is quite interesting, and this shows something that's quite different to what we see in postgraduate learners. So this is the analysis broken down by knowledge-based outcome measures and clinical performance-based outcome measures. Now what you see in postgraduates is that simulation is effective in both of these measures. But actually in medical students, we found no evidence that simulation was effective for teaching facts and knowledge. But compared to clinical performance where simulation was effective. And I think there are a few potential reasons for this. And I think that's because what simulation does is it helps us transition through the different stages of learning. So this is Miller's pyramid. It's quite basic learning theory. And what this says is that we basically start with fact gathering, and as we learn, we sort of start knowing, and then we know how, and then we begin to be able to show what we've learnt, and finally we'll be able to perform or carry out those tasks. So I think the simulation is what helps us move through here, and I think this might be why simulation is effective for clinical performance and not knowledge in medical students. And I think when you're a more expert learner, so perhaps the more senior doctors, I think that's why perhaps the knowledge side of things can come across, because you already have that kind of basis there. So the other thing we looked at, which I'm going to talk to you about quickly, is the difference between the different types of simulation. The main analysis that we did include the other types as well, but these are the most relevant. So we're just comparing high fidelity versus low fidelity. We found that high fidelity was much more effective, and this is mirrored in quite a lot of research. Interestingly, the studies looking at low fidelity simulation versus other teaching methods had quite significantly varying results, and I've looked at those two papers in quite a lot of detail, and I can't really see why there's that difference. So I think we can safely say that simulation is probably, high fidelity simulation is probably more effective than low fidelity. But it's difficult we can't entirely 100% say that from this. So the implications of this. So I think we can say that simulation is highly effective in improving performance in clinical-based assessments in medical students, despite reasonably short simulated sessions. So in all of these studies, I think the maximum simulated session was about 2 hours. So even short exposure to simulation can have a massive difference in medical students. And we can say that high fidelity simulation appears to be more effective, but we found no evidence that it's useful for knowledge-based assessments. So I think, therefore, that simulation, when we're teaching these kind of technical skills, should be used alongside other teaching methods which are aimed at knowledge acquisition. And just quickly talk a little bit about the mitigation of ethical tensions. So with teaching critical care medicine and acute care skills, it's very difficult for medical students in that with these kind of situations, tensions often run very high, the opportunity to gain consent from patients is limited. And often following emergencies, the opportunity to debrief can be limited by the need to get back to what you were doing, perhaps when you were alerted to something going wrong on the ward. So I think the use of simulation in exposing students to this kind of medicine before they hit the wards as F1 would be useful. So the last thing I just want to talk about is the directions for future research here, and I think this is equally as important. So we've shown that simulation is effective in medical students, but what we can say for sure is that simulation isn't always effective. And I'm not sure I can entirely explain why it's not always effective. And I know there's quite a lot of work that's been done, certainly in recent years, but I think perhaps characterising further why some of these studies are different would be useful. And I think that's partly down to the design of those studies and the reporting of them. It's very difficult to break down why there are differences there. The next thing is that simulation, we've shown that it's useful for improving performance in clinical assessments, but what we haven't shown is that simulation actually changes patient outcomes and what happens after the students get out into practice. There's obviously work, I think, that needs to be done in cost-benefit analysis here when we're spending quite such large sums of money in simulation. And as most of these studies were small and quite variable, there's really a need for sort of larger and higher quality research with better reporting. Part of that comes down to adhering to the standard guidance on design of research, and we followed the Cochrane handbook in designing this research, but there's also Beam as well, which have extensive procedures in terms of designing this kind of research. And I think in education it's really time that we started making sure that we're following that kind of guidance. The other thing that would be useful when it comes to comparing these kind of studies is the development of standardised and validated teaching scenarios and assessments. So all of these different papers all used a different scenario, and they all use different exams, different assessments, different scenarios in the clinical assessments. And that makes it very difficult to compare all of these studies and put them together. And I think these are some of the things that would be useful. Now, I'm sorry that I've not had a lot of time to go through things in lots of detail today. Those are the references to all of the papers that were included. The full manuscript's been accepted by Simulation in Healthcare and has been through production, so that should hopefully be out in the next few months. And as I said, the protocol's available online, and there's a link if you're interested. So please do have a look, and if anyone wants to find out anything else, I'd be happy to take some questions later on.